Right. Well, hello, everyone. Thank you for joining us for the Canadian Liver Foundation and the University Health Network Ashmere Transplant Center, a quarterly webinar series on liver disease and liver transplantation. My name is Ned Maximovich. I'm the Senior Manager of Support and Education at the Canadian Liver Foundation, and I'll be the moderator and host for this webinar. I'd like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. The Ashmere Transplant Center and the Center for Living Organ Donation at UHN are located on traditional territory of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and now home to many diverse First Nations, Inuit, and Métis people. This is the third session of our quarterly series. In our first session, our speakers discussed liver disease, the clinical management and treatment options for liver failure. In our second session, speakers talked about the pathways to liver transplantation and the living donor assessment process, along with the surgery and recovery. In today's session, our speakers will discuss the pre-transplant journey, anywhere from the referral process to the assessment process, along with aspects relating to the transplant waitlist. We will have two speakers, our healthcare professional speaker and our patient speaker, followed by our question and answers at the end of the session. So we're joined today by Dr. Nazia Selzner, a transplant liver specialist in the multi-organ transplant program at UHN, and associate professor of medicine at the University of Toronto, as well as our liver transplant recipient, Maria, who will be sharing her story today with liver disease and the transplantation process. So please feel free to use the comment feed to ask your questions during the presentation, and note that questions will be answered following both speakers' talks. The session will be available post-event on the Canadian Liver Foundation and Center for Living Organ Donation Facebook and YouTube pages in the coming days. At this time, I would like to welcome our first speaker, Dr. Nazia Selzner, transplant hepatologist. Dr. Selzner will be providing us with an overview of liver disease and the transplant system process, along with other aspects of the waitlist criteria to address all the concerns and potential confusions that some of you may have encountered through this process. Dr. Selzner, I will hand it over to you.
Good evening, everyone. Thank you so much for this kind introduction, and it's my pleasure to review the steps of the pre-transplant journey and hopefully answer some of the question that is maybe remaining by the end of this presentation. So just before we talk about the pre-transplant journey, a few reminder regarding our transplant program, the Ashmere Transplant Program here in Toronto, located at Toronto General Hospital, that we are the largest liver transplant program in Canada and one of the largest in North America, with excellent patient outcomes, and that is yearly reflected and evaluated to maintain this outcome, and we have published our results extensively in that regard. We are the largest North American live donor liver transplantation with a program that has now over 22 years experience in living liver donation. And we have performed over 1,000 living donor surgery. And we also provide patient care follow-up to over 2,000 liver patients post-transplantation from across Canada. Next, please. So this diagram shows some of the common types of liver diseases that require or can be treated by liver transplantation. This is the data not from our own center, but is Canadian data. And as you can see here, the largest proportion of the patients that require a liver transplantation fall under the category of unknown, and this include patients with mainly now mostly with what we used to call cryptogenic or unknown patient with liver disease, and currently majority of these patients are fatty liver associated or non-alcoholic steatohepatitis-induced liver disease. We have a lot of patients with cancer on background of various types of liver disease that require transplantation. Patient with alcohol-associated liver disease definitively are large indication and rising indication for transplant, and various type of hepatitis, including viral hepatitis such as hepatitis B, still remained a good indication for transplantation. Although the little sister of hepatitis B, which is hepatitis C, has now been mainly cured for by the treatment, the medications that are available, and therefore hepatitis C alone as indication for transplant, the rate of this cause for liver disease and indication for transplant has significantly reduced over the last decade due to development in the medication. Next slide. This is a study that was recently published and looked at the burden of non-alcoholic fatty liver disease, or NASH. As I mentioned, in Canada, this is a Canadian study, and the study is very interesting because it shows that similar to the US, in Canada, there is an increasing rate of fatty liver causing end-stage liver disease and liver cirrhosis, and the projection is that the number of patients with fatty liver disease would increase by 20% between 2019 and 2030. And can you imagine that? You can imagine that this rise of almost by 25% would increase the burden and the need for liver transplantation over time. And that reflects at various stages, but also increase the number of the patients with cancer on the background of this fatty liver that require liver transplantation. So what are the signs and symptoms of liver disease? Those signs and symptoms are on these slides. Often patients with liver disease have jaundice or their skin and the color of eyes has changed to yellow. They have this dilated veins on their skin that look like spider's navi or spider veins. Sometimes they have developed symptoms of liver disease in terms of fever, particularly in patients with bile duct associated liver disease, such as PBC or PSC. They can develop cholangitis, pain over the area of the liver on the right upper quadrant of the abdomen, swollen ankle, dark color of urine, changes in the appearance of their bowel movement. Sometimes the color of the bowel movement is a little lighter. Fluid retention in the abdomen, the word that we use in medicine is ascites. So those are patients who develop swelling in their abdomen and require to undergo a needle insertion in some instances to remove the fluid. Fatigue and confusion are other symptoms of end-stage liver disease. Same as change in sleep pattern. The patient with liver disease are often wide awake at night and they need to sleep during the day. These are change in patterns. Itching as a result of the jaundice and accumulation of a bilirubin, which is a pigment under the skin. Bruising and bleeding are often sign of liver disease, as some of the coagulation parameter is sensitized by the liver, and muscle cramping. So as you can see here, there are a number of symptoms that could be potentially related to liver disease, but also there are instances that liver disease manifests itself without any particular symptom until at a very early, late stage of the disease. So who should be referred for transplant assessment? There are 3 different categories of patients that would benefit from assessment for liver transplantation. The majority bulk of those patients fall under the first category. These are patients with end-stage liver disease or liver cirrhosis that have shown sign of decompensation, and those sign of decompensation is marked here on the slides: ascites, fluid accumulation, either in the abdomen, but sometimes ascites can even accumulate in the thorax. It's called hydrothorax, and these patients often have shortness of breath and difficulty for breathing. Infection of this fluid can be another manifestation or decompensation related to liver disease, and it's actually a very concerning decompensation. Jaundice, hepatic encephalopathy, as manifested with trouble for sleeping, difficulty for concentration, memory, sometimes even mood changes are symptoms of hepatic encephalopathy, as well as symptoms of bleeding are sign of decompensation. So any patient with end-stage liver disease who has these symptoms should be referred to a liver transplant program for assessment at least. And the other category of patients with end-stage liver disease who may not have one of these symptoms, but are still eligible for transplantation and should be assessed, are those patients are falling into this category, special categories, with hepatopulmonary syndrome, which is opening of some specific shunts in the lungs, and this is associated with the liver disease, and patients develop difficulty for breathing, shortness of breath, and requires in some instances oxygens at home. And the other big category, obviously, is patients with liver cancer or hepatocellular carcinoma. The second big category of patients that should be referred for transplant are those without having underlying or chronic liver disease, but who have been otherwise healthy and suddenly develop for various reasons, whether it's related to a viral infection or some medication they have been on, they are going to develop fulminant hepatic failure. This is a very devastating but thankfully rare situation in which a healthy individual suddenly goes on to develop liver failure and require urgent assessment and transplantation. And the third category are those very rare but yet definitively indications for transplant with metabolic disorders such as hyperoxaluria or amyloidosis, etc. Next. So when should a transplant referral happen? I think that I always say this when I have one of these educational events, that it's always better to refer a patient for transplant sooner than wait too long and be too late. It's never too early to refer someone, and if in the worst case scenario, we as a transplant assessment physician would make a decision that is too early, and would refer the patient back. But generally, the decision to send a patient for transplant is made based on utilization of a model that predicts the rate of mortality based on the number that is calculated through this model. The model is called sodium MELD, is a specific mathematical formula with 4 different parameters to reach a number that could be as low as 10 or as high as 50, and it's plateaued around that area. So sodium MELD score allow to predict what is the mortality on the waiting list for a patient within a period of 3 months from the day the score has been measured. And if someone has a very low score, for example, 10 or 11, the rate of mortality between the first 3 months is generally low. However, as the score rises, obviously this mortality increases. And the formula take into consideration parameters from the blood work that includes bilirubin, INR, a coagulation parameter, creatinine, representative of the kidney function, and serum sodium concentration. So who can be referred to the UHN liver transplant program? The referrals are generally accepted from physicians. It could be a family physician, it could be a gastroenterologist in the community, or a hepatologist. Any of those physicians can send a referral to us. This is the form that the physicians are generally used to refer the patient to us. They put some of the information regarding the manifestation or the symptoms that I described, and they refer this, and we review this form, and based on some of the information that is provided here, we decide whether a patient needs to be seen urgently, meaning within a week or 2 weeks, or can be seen within a period of 4 to 5 weeks. This is on average the latest time when a patient is seen upon referral. And we accept referrals from across Canada, and we have recently also considered to open a referral in particular instances and condition to perhaps for second opinion from centers abroad. So where should the referral be sent? The referral should be sent to this building. That's Toronto General Hospital, the transplant program. And the address for the referral is written here for those who are interested to know where the referral should go to. Next. And how does the liver assessment process take place? There are a few steps that are outlined here. As a first step, the liver specialist or hepatologist will send the referral to us. It could be a gastroenterologist. That's a package that includes this form, plus some of the tests that have been done through those physicians. And then the patients, this referral is reviewed by us. We then arrange to see this patient now more and more in person. Over the time of the COVID, most of the referral assessment were done virtually. And the transplant team will review all those tests and arrange to see the patient and speak with the patient and examine them and make sure that they do in fact have the indication for transplant. Following that first assessment, if the team feel that the patient meets the criteria, we will start the evaluation for liver transplantation, which include a number of tests in order to assess the other organs in a patient, including their heart, their lung, their social situation, their drug coverage, their and some other testing to rule out other type of hepatitis or serologies in this patient. And once all these tests are completed, we do have a weekly a meeting where all the patients who have gone through those testing are reviewed by all the member of our team, the staff transplant hepatologists, the surgeons, the social workers, the member of anesthesia are on this weekly meeting, and we review one by one the packages. And if there is no contraindication from the testing and a clear indication that one needs a transplant, then we will move on and we put the patient on the waiting list for transplantation. And what you need to bring for the first appointment, it's important to make sure that you bring the list of all the medication that you are taking, whether it's a prescribed medication or over-the-counter medication, all the herbal supplements, vitamins, etc. If you need to mention if there has been any change in your condition since you have been seen by your doctor. It's very, very important, and we highlight it all the time, that it's really helpful to have a support person with you, even when you come for that first assessment to transplant center. That support could be a family member, a friend, someone who could be there and listen to all the information that is provided, because often that meeting is quite overwhelming with a lot of information. And it's important to have someone who can listen and remember some of those information and navigate you through the process. And also it's important to bring a list of all the questions that you want to ask, because often a lot of patients, when they feel that they have all the questions in their mind, may forgot what question they wanted to ask. And those first visits are generally the longer one, and sometimes it could go beyond an hour of consultation. So these are the timing and the location for the liver clinic. So the assessment clinic is a Tuesday clinic. That is where we see all the new patients that are referred for transplant. For those patients who move on to get their test done and go on the waiting list, they are then moved to a pre-transplant clinic, which happens every Wednesday afternoon. And in this clinic, only patients who are awaiting a liver transplant are seen. And once they have received the transplant, they move on to the post-transplant clinic, which, depending to the hepatologist that is involved in the care of that patient, could be Monday, Tuesday, or Thursdays. And the location is at Toronto General Hospital. So these are some of the tests that are required for a patient to be put on the waiting list for transplant. I alluded to some of those tests. Some of these tests can be done by your referring physician. So it's important to know that not all the tests needs to be done here at TGH. Some of the tests can be done locally. However, in some instances, it's important to get this done here, because sometimes the tests are faster when they are done at TGH. In some instances, we require biopsy, but those are rare instances. However, we do need cardiac testing from all the patients. We require imaging, so abdominal ultrasound. We require the copies of any endoscopy that was performed, whether it's the upper or lower endoscopy. And we also want a respiratory function test to look at the breathing capacity of a recipient. The test that is for cardiac workup needs to be checked again on a regular basis annually if the patient haven't been transplanted during that 1 year period while their assessment has been completed. And in addition, there are some blood work, chest X-ray and EKG that are also mandatory for the clinic appointment. So this is a checklist for the transplant approval process. All required tests and consults have been completed. All recommended follow-up and required treatment have been completed. You have met and talked with all members of the transplant team involved in your evaluation, and you want to have a transplant and understand and accept what is required before and after transplant. And that is a very important piece to keep in mind, that requirement to adhere to all recommendations before, while waiting, and after transplantation is a mandatory need from all patients in order for them to be accepted for transplant and be followed afterwards. So there are a number of pros and cons to consider, because transplantation is not right or is not possible or feasible or acceptable for everyone. In terms of what are the pluses, when a liver is cirrhotic and is changed, the health of the recipient significantly improves, their energy is improving, their thinking and their processing improves, they have a better memory, their overall health is improved, their longevity or lifelong longevity is improved, and they don't have any longer those fluid restrictions, and they don't need to follow a diet with salt restriction, fluid restriction, etc. However, transplantation also comes with its own baggage of perhaps what we call negative consequences. It requires a follow-up for life and care for life, requires medication to be taken every single day, twice a day for life, otherwise the graft is lost. One has to keep in mind that some of the diseases, particularly the autoimmune diseases or fatty liver disease, may recur or come back again on the graft. Transplantation is a major surgery, so there are complications, and definitively there are side effects related to the transplant medication that one has to take for the remaining of their life. So it's very important that one keeps these negative consequences of transplantation along the positive side of it when the discussion of transplantation takes place, and we try always to navigate and ensure that the patient, recipient, is informed of all of this as we see them for the first time. The general listing criteria for liver transplant is other therapeutic option has been exhausted. So if there are other ways to treat a patient with end-stage liver disease to buy side time and delay the transplant, that's important. That we also have to make sure at the same time that there is no obvious contraindication or reason not to be able to move ahead with transplant. And we always say that the expected 5-year survival for a liver transplantation should be beyond 60, ideally beyond 70%, in order to put a patient at risk of this major surgery before we go ahead. So the timing going on the waiting list and waiting for transplant is very critical. The best timing is when the liver starts to show sign of decompensation, but the recipient is not yet too sick, particularly has no other end organ damage from the liver disease, and those are the ideal candidate and the ideal timing to go on the waiting list for transplant. But also the safety of the procedure should be kept in mind. although some patient may get approved, they may be, it may be medically unsafe for them to move ahead with a liver transplantation. For example, those who have advanced heart disease, patients who have other cancer beyond their liver cancer, or have uncontrolled infection. Those are generally contraindication to transplant, because not only we cannot salvage or increase their life expectancy, but also we can actually dramatically decrease their life time. So the listing contraindication or parameters to keep in mind are the following: nutritional status. So if someone is extremely frail and the condition, or in contrast, if someone has a very high BMI above 45, those patients are not transplant candidates. Ongoing infections, as I mentioned, because immunosuppression and ongoing infection would make these patients a lot worse and a lot sicker and can jeopardize their life. Malignancy outside the liver, this patient with malignancy, once they start on immunosuppression, there is no longer any control of immune system over this malignancy, and they can really die very fast from worsening of their cancer. Some vascular abnormality could be also a contraindication, and obviously there are a number of psychosocial considerations to take into place when we assess this patient. This include uncontrolled or unstable psychiatric disorder, illicit use of the drugs in the previous 6 months, unwillingness or inability to follow medical advice, and this includes also taking all the medications. So you have probably are aware that the listing criteria for patients with alcohol-associated liver disease has changed, at least in province of Ontario, and to my knowledge, many other provinces in Canada also have moved from what we used to call the 6 months abstinence rule to a new set of criteria that are listed on Trillium Gift of Life Agency and are available. But generally, this criteria takes into consideration no longer the length of how long the patient was abstinent from alcohol, but take the patient as a whole, including their severity of alcohol use disorder, their willingness to remain abstinent, their insight into understanding of how alcohol has caused damage to their liver, their participation in the relapse prevention treatment, as well as their psychosocial support. So any patient with one of these blood type group here can receive normally a liver from the blood group in this way. So if you are a blood group O, you can only get a liver from someone with a blood group O. If you are A, you can get a liver from blood group A or O. If you are B, from a donor with a blood group B or O. And the ABs are those that we call the lucky one, because they can receive an organ from a donor that has a blood group A, B, AB, or blood group O. This is the data from the Canadian data as of very recently, as of a couple of days ago. There are 417 Canadian patients that are active on liver transplant nationally, waiting for a liver transplantation. And in Ontario, we have 169 male and 85 female waiting for transplantation. And these are their distribution or of their blood group. As you can see here, majority of the patients who are waiting for transplant are waiting for a blood group, blood O type. and blood is followed by A blood type patients, recipients. Blood group B type is the third less frequent, and AB are only very few patients waiting for a blood group of these categories. This also is important information that I wanted to share with you. Here on the left-hand side, as you can see here, roughly 28 or 30% of all the listed liver patients die every year waiting for transplant. This is the information from 2020, but the number has been very stable over the last 5 years. Around we lose about 30% of our patients on the waiting list. And about 20% of the patients are removed every year from the waiting list for transplant. These are the patients that are put on hold or removed either because they get very sick and we have to put them on hold, or on the contrary, they in some instances they may improve, and that's the reason for removal of them. But the majority of them is also include patients that have become very sick and we have to put them on hold. And if you add those two together, roughly 50% of the patients on the waiting list either die or put on hold for transplantation. This is again the Canadian data and not just from Ontario. And I wanted to bring to your attention and complete this presentation with a very recent published, we call it hot out of the press, paper from our own program, where the data from 3 big countries, Canada, US, and UK, have been pulled together to look at the outcome of patients recipient with living donor liver transplantation. And this paper very nicely shows that despite the fact that the outcome of recipient of live donor liver transplantation is excellent, and we have looked at that in our own program separately from this study, the outcome is actually similar to deceased donor liver transplantation. The utilization of this procedure still remains very low. In Canada is definitively higher than other countries such as US and UK, and particularly as our program has been really pioneering that field. But still many, there are not as much utilization of this strategy to increase the access to liver transplantation and save life of those 29% of patients that die every year on the waiting list for liver transplantation. And next slide. Who to contact to get more information? Transplant Liver Clinic, recipients, pre and post transplant. You can go on uhnTransplant.ca. Living Liver Donor Office for assessment of donors, living donors, and their follow-up, livingdonorliver@uhn.ca. And of course, the Center for Living Organ Donation that provides education, peer mentorship for donors, for the recipient, for the caregivers, and is there to navigate and help and troubleshoot all along. And these are their contact information. The center has also a number of useful resources for all of you who want to learn more or need more information. There are very good infographics about finding a liver donor. Often this is very challenging for a recipient to find the appropriate donor, or even approach to someone to discuss about living donation and what are the steps to take in that direction. There are a number of other resources. We have donor champions that have been out and help in the community. community, everyone in needs for liver transplantation, navigate through that and provide their time generously to help anyone in need. And all these useful resources, as well as manuals, guides, etc., is all available through the Center for Living Organ Donation in Toronto. And the center, we also provides a number of education sessions, webinars. Some of them are in collaboration. For example, the one that we are having right now with Canadian Liver Foundation, and a number of these webinars are listed here and is available online for those who are interested. And with that, I would like to pass on to Maria Morey, who is one of our, the recipient of a living liver donor recently, to share her own story about living organ donation. And thank you. Maria, please go ahead.
Hi, good evening. Can you hear me okay?
Yes.
Okay, thank you. Thank you very much, Dr. Selzner, and good evening to everyone. I'm so thankful that I was invited to speak today about my journey with liver disease, and specifically my pre-transplant story. I do have a post-transplant story, but I think that's probably another session. So today I wanted to focus on the journey of getting a transplant. So a little bit about me. My name is Maria Morey, and I'm 52 years old. I'm married and have a 13-year-old son who just entered high school professionally. I have a degree in nursing from U of T and have worked in the field of public health and nursing management probably for the last 30 years. I live in Brampton, Ontario, and I have Portuguese background. I've been generally well and healthy for most of my life, and other than having Raynaud's disease since my early 20s, which is an autoimmune disease where the little blood vessels restrict mostly in my hands, feet, fingers in cold sort of temperatures. It's kind of like having frostbite. So I should probably move somewhere sunny and hot. I have primary biliary cholangitis, and that's referred to as PBC. It's an autoimmune disease that attacks the bile ducts of the liver. So in my case, it progressed over 4 years that I know of. And then I had to get a liver transplant due to cirrhosis of my liver. So luckily, my story is a positive one, as I was blessed with a living liver donor that saved my life just a year ago on August the 30th, 2021. So I've just celebrated that. And some of the pictures that you see are of my 1-year celebration, where we had family friends come up to Arthur, Ontario at our trailer. And we had a fundraiser. So we raised funds for the PBC Society, the Canadian PBC Society, as well as for the UHN transplant program. I'm so grateful for the massive healthcare teams that I had, both at William Osler Hospital in Brampton, as well as the UHN Ajmera Transplant Center, the UHN Center for Living Organ Donation, and foundations like the Canadian PBC Society, supportive family and caring friends, and as well as strangers, which I was really shocked that there are good people out there that care. And they kept me positive and very encouraged while I was barely living or even existing. That's how I was feeling. I was always very, very tired, exhausted, and on the couch sprawled. I was scared, anxious, and worried all of the time. I couldn't sleep. It's ironic to say that COVID helped me during a difficult time in my life. I was able to work from home. I had virtual medical appointments where possible, and I was able to rest here and there while I was working. Of course, the downside of COVID was the fear of getting it, as I was so immunologically vulnerable to infection, and that many times when I was at the hospital for procedures and treatments, I was alone. And I felt very much on my own with this very complicated and uncertain disease. I was terrified of my future. It's not every day you hear about liver disease, and especially in my family, which there's no history. I've managed to dodge COVID with strict, knock on wood, strict restrictions and no visitors during that time. And still, I am very cautious and do have my up-to-date immunizations, vaccination. Thank goodness for FaceTime though, where I could call several people while I was in treatment and just to help me pass the time. One of those people was my mom, who was terminal with ovarian disease overseas. And this was a very emotional time for me in a personal way and in a family way, right? It was me giving my mom support, and in turn, she was being my mom and telling me it would be all right. Unfortunately, she passed away 3 months to the day after my transplant. And I know in my heart that she was just waiting to see that I was out of the woods. Today, I'm very grateful, strong, and feeling well. I have a lot to be thankful for and to live for. I want to go back now and share with you a little bit about how my story began. I started feeling unwell in 2017, at which point I had my gallbladder removed with a stone measuring 3.5 centimeters. My surgeon didn't like how my liver enzymes weren't returning to normal and suspected additional small stones that were stuck in the bile ducts. He did a test and it seemed clear. So there were no additional little stones. He sent me back to the family doctor, who then sent me to the gastroenterologist specialist. And from there, you can imagine that I spent a lot of time with follow-up appointments, which were every 6 months. And still, I didn't have any concrete answers or diagnoses. I was then sent to a hepatologist with query PBC and put on some medication called ursodiol, and that would help to protect the liver from cirrhosis. I was so confused at the time. I was not a drinker at all. So how could this be happening to me? I started to Google PBC and was terrified to read the outcomes. So I highly recommend that people that are newly diagnosed do not do that. Look for credible information, such as becoming a member of organizations, such as the Canadian PBC Society and other Facebook groups, to learn about the disease and from people living with it. The hepatologist did a fibroscan, which is like an ultrasound of the liver, which then confirmed the diagnosis of PBC. And I was at stage 1, fibrosis of the liver, in 2019. So for those that don't know, there are 4 stages, and stage 1 is some scarring or fibrosis of the liver. I continued on the medication and I began to have new symptoms, like feeling so utterly exhausted, fatigued. I slept and rested all the time and when I could. I had a colonoscopy and endoscopy, which ended up repairing multiple esophageal and rectal varices. So these are varicose veins in those 2 areas, and they bind them. And then I continued to have gastrointestinal issues that were like belly cramps and diarrhea. And I lost 40 pounds during that time. I had no appetite and became a little foggy in my thinking. And I also fell a few times. By the end of 2020, I had severe ascites, which is fluid in the abdomen, and was removing up to 10 liters of fluid from my abdomen weekly and left the hospital each time, each Friday usually, 20 pounds lighter. I certainly felt like I had a bikini body every Friday heading into the weekend, but unfortunately it didn't last beyond the next day. I saw a UHN hepatologist at the liver clinic that tried to manage my ascites and reduce the amount of paracentesis I was getting. Paracentesis is the draining of the fluid in the abdomen. I had to journal my diet for 3 months, aiming for no to low sodium and high protein in my meals. So that was kind of difficult of even figuring out what to eat. I was on 2 diuretics that were causing me kidney issues with high creatinine, so I had to stop those. I was pretty much miserable, not hungry, losing muscle mass and my strength. My mouth and gums were so sore and strange looking. It's like my mouth was shrinking. I felt like I was 12 months pregnant and I had a huge negative body image with such a big belly. I didn't even want to go out in public. And again, COVID saved me from that. In the end, pre-transplant, I had 48 paracentesis and I was so done. I came to understand that I was in stage 4 decompensation, end-stage liver disease with cirrhosis. I was at the end of the continuum that we always see in the doctor's diagrams, where there was nothing left, no other stage to go to, and I was so scared. My MELD score that Dr. Selzner talked about became high enough, coupled with my symptoms, to be referred to the UHN transplant program, the Ajmera transplant program. And that was done by my hepatologist at the William Osler Health Center. And this was at the end, just before Christmas, 2020. I stopped working, not by choice, as I had an emergency hernia surgery and never went back to work after that. This was caused by the pressure of the ascites on the belly button. My colon was twisted outside my body and it became an emergency. At the UHN transplant program, I began lots of evaluation tests like blood work, ECG, pulmonary function test, CT scan, abdominal ultrasound, nothing invasive and difficult at all, as well as consultations with social work, anesthesiology, pre-transplant nurse coordinator, fellows, transplant doctors, and finally, 3 months later, I was placed on the list for a liver from a deceased donor, and that was March of 2021. I should have been so happy to be on the transplant list, but my emotions became so mixed because it was real and it was confirmed that I had cirrhosis. I had questions like, are they sure I have cirrhosis? How do they know? They haven't looked at it. There was no biopsy done. I don't feel pain on my liver. Now I was really scared. I couldn't sleep. I was worried. I was depressed and anxious. Family doctor put me on antidepressants and anti-anxiety pills. I reached out to EAP for a few sessions to talk about my feelings, which did help a bit. I spoke to family, friends, and outreach to the PBC Society and others on Facebook groups, silently observing the topics and the discussion and the experiences, comparing symptoms to mine, learning about the lingo like TIPS, hepatic encephalopathy, and different medications. I had no idea what to expect or how long I'd wait for a transplant, but what I did know was that I began to have severe itching, quicker filling of fluid in my abdomen, discomfort, and extreme fatigue. This was not living, and I couldn't see past this point. I was deflated when one of the transplant team doctors said that it could be a very long time before I could get a deceased donor transplant. It could take months to years because I wasn't that sick, that I wasn't hospitalized, I wasn't, top on the list. She suggested I explore living liver donation. And I thought this was crazy. Who would give me 60% of their liver? My family wasn't a match, and I'm a pretty private person and had to really come to terms that the only way to get better was to reach out to others in my circle and beyond to find that match. I was inspired by a friend of a friend of a friend, someone I didn't know. He was a 23-year-old young man who put out on social media a campaign on Instagram for a kidney. He got his transplant 2 months after I did, so that's good news for him. I thought, I can do this. I took to Facebook and created a page called Maria Liver for Life. And I told my story. I was shocked. I received so much support from family, friends, acquaintances, strangers who gave me encouragement, motivation, shared my story, liked my story, loved my story. And I continued with updates along the way, and people were really interested. The power of social media is incredible. I searched and found the Center for Living Organ Donation and reached out to them to help me with my storytelling. Was it good enough? What other methods could I use to get the word out that I needed a liver? The outreach coordinator put me in touch with great resources and webinars that they host, as discussed tonight, and I learned a lot. Within a matter of a couple of weeks, I had 6 people registered to be donors, which was, I was in awe. And they were registered with the Center for Living Organ Donation. And, you know, it's an 11-page form. I looked at it to get registered. So people, you know, that didn't stop them from applying. Many others wanted to, but their blood type wasn't a match. I felt so humbled and honored. My first potential donor went through the process of testing and evaluation beginning May of 2021 and was approved in July of 2021. Felt like forever, but in retrospect, it went quick. My donor is a friend of mine that is part of a mom group that I belong to, a group of 8 supportive moms and friends to this day for 13 years. When I asked why my donor wanted to do this, she said it was a choice, not an obligation. I'm so thankful to my hero for her great act of kindness. It's left a mark, just like the recent campaign at the center. Great actions leave a mark. It's a visual symptom. My scar is a visual symptom of hope in the battle of PBC. With that, I thank you all for allowing me to tell my story, and I'm grateful to share it with others to raise awareness about the scientific miracle of passing on life from one human to another. Thank you.
Perfect. Thank you, Maria, for sharing that remarkable story, and Dr. Selzner for the intro talk. We'll take just a few questions here. We'll have one for Dr. Selzner and one for Maria, and then maybe we can kind of have an open discussion towards the end. I suppose the first question that popped up was what folks can do while they're actually waiting on a transplant list. So Dr. Selzner, I know you mentioned some aspects in terms of quality of life and what people can do generally. Is there anything that you would recommend somebody who's been on the wait list for perhaps 6 months or a year, what they can do from a nutritional standpoint or a lifestyle perspective that would help them during this journey?
So I think that the most important thing is to keep both mind and body healthy. So in terms of the physical health, so proper nutrition, exercise as much as the body is obviously able to tolerate it. We don't ask people to go, you know, do a marathon, but keep daily walks, whatever their body is allowed them to do. No alcohol, no smoking, no substances. These are in terms of keeping a healthy body and being as fit as possible to go through a big surgery. And mental health is the second important part of the equation. I do believe that Maria touched upon some of the aspects related to COVID, and but I do believe that COVID have had a significant impact in terms of the burden of liver disease, and particularly for those who are waiting for a liver transplant and are unsure of when the phone will ring and when does that live donor will become material. And you know, keeping those mind setting on toward the right direction, whether it's through the help of the family, support of the friends, people through the community, or even seeking help from professionals are, in my mind, are extremely important. So mind and body. I'm sorry, for some reason, my light always goes automatically off, and it's not that I'm stretching, I am just triggering the light to come back.
Perfect. Maria, do you have anything to add on that question with respect to what individuals can do from a physical or mental health perspective, maybe perhaps from your experience?
Sure, Nam, thank you. For me, one of the stronger things was the mental capacity, how it plays on the mind, right? Like I, very early on when I got the you know, you're at stage 4 and you need a transplant, I thought of death. And that's all I could think of. And, you know, I have a 13-year-old son. I haven't lived my life yet. I, you know, have so much to do, so much to live for, that it really took its toll on my mental ability to cope. And reaching out to, you know, my work benefit with EAP. And, you know, I wasn't able to really talk about my true feelings in the family because I didn't want to worry them about my feelings about, you know, end of life kind of thing. And so it was very helpful to talk to a stranger and someone who was, you know, non-biased about the situation. Physically, like I said, I was pretty full of fluid, and my physical activity was from the couch to the kitchen, which are almost in the same room, and I'd be out of breath. And I wouldn't be going upstairs a lot during the day because I just couldn't. So I think just to you know, nutrition became an important factor where physical activity was so limited, but stretching as much as possible, because you do get stiff. You know, you do. From a lot of people that worked at home during COVID, you know, we sat a lot more, and you could relate to being, you know, that much more stiff. That imagine somebody who's diseased. So I think I agree with Dr. Selzner about the mental and the physical abilities, and just focusing on that and keeping positive, because transplant and living donor is a reality. I did not believe it would be for me, but I am here to say that it is, it's amazing. UHN program has been nothing but supportive and fantastic experts, and to this day, the follow-up that I receive is amazing.
Great, thank you for that. We'll just do one last question here. Perhaps Maria, you can touch on it as well. It's from the caregiver perspective. Most people who reach out to the foundation on our end, when they're in this pre-transplant journey, oftentimes the caregivers or a family member would actually reach out looking for ways to assist, even though the individual is sick, whether they're very advanced liver disease or just starting their journey. So perhaps from a caregiver perspective, any suggestions or tips or insights that they could use that would be helpful for them if they're looking after someone with advanced liver disease and possibly going through the pre-transplant journey themselves?
So in terms of caregiving on my end, my husband was my caregiver, and he was very available to help me. He's always cared for the family in a way that looks after, you know, he cooks, he cleans, that kind of thing. So that's always helpful if you have that available as part of your support system, because that's the last thing that's on your mind. But in terms of nutrition, you're making sure that your caregiver is paying attention to the kinds of foods that you're consuming, as we talked about, like no or low sodium and how important that is in the diet, higher protein. For me, those were the two things that I was recommended as being low within protein being low in my diet. So, you know, having a caregiver that's willing to go all out and try different things for you, because as a patient, as an impatient nurse, I was, you know, out of ideas of what I wanted to eat. I wanted nothing, but you have to sustain yourself. So I think it is difficult as a caregiver. Post-transplant, I did have reaction to medications, and my husband was really afraid of the behavior that I had. And he had to seek additional support from the mental health nurse, nurse practitioner, and discharge nurse on site to say, this is normal for your wife to be feeling, and you know, we're giving her medication, we're supporting her, we've got an observer for her during the night to just to make sure that she's safe. So as a caregiver, they don't know what the disease process, what the medications can do. So to have them also have additional resources that they can outreach to would be is very important, and it's available. Thank you.
Perfect. Thank you for that, Maria. So we'll conclude there with the presentation and the Q&A. So that final answer, that's the end of this webinar for this evening. I'd like to take the time today to thank both of our speakers for their great talks. I also want to thank our partners at the UHN Ashmeyer Transplant Center, and of course the Center for Living Organ Donation for helping with this educational webinar series. So as mentioned earlier, this webinar will be available on both the Canadian Liver Foundation and the UHN Facebook pages and YouTube channels in the next few days. So if you haven't got a chance to watch this video live, or would like to go back on a few slides that Dr. Salzner was presenting, the webinar will be available in the next few days. To learn more about liver disease or to find out about the Canadian Liver Foundation, please visit liver.ca, and please be sure to follow us on social media for all the most up-to-date information on liver health tips. And for information on the Transplant Center and the living donation, visit uhnTransplant.ca. So our final session for the series will be held in November. It will be November 23rd. So this session will focus on the post-transplant journey. So tune in in November for this presentation on the post-transplant journey. As you can see, the 4 series highlighted the entire journey from liver disease and indications for transplant to living organ donations to now the pre-transplant, and eventually finishing off with the post-transplant journey. The registration link for these events will be available on both the CLF website, on the Facebook pages, as well as the UHN Facebook page as well. So thank you all for attending tonight. Until next time, and take care.